Assalamu alaikum. Our lecture today is about nutritional disorders. Classifications of malnutrition it include either undernutrition like marasmus, overnutrition like obesity and hypervitaminosis, specific deficiency of specific substance like kwashiorkor or hypovitaminosis. It could be a mineral deficiencies, or lastly, it could be due to imbalance like electrolyte imbalance. Marasmus result from the body's physiologic response to the inadequate calories and nutrients. The patient will have loss of muscle mass and loss of subcutaneous fat store. It can be confirmed by inspection, palpation, and it can be quantified by anthropometric measures. The head of the patient with marasmus will appear large, however, it is proportional to the body length. Edema is usually absent. Can be used to differentiate it from the kwashiorkor. The skin of the patient with marasmus is dry, thin. The hair will be thin, sparse. It is easily pulled out. Also, they will have an apathic facies. They are weak and may be irritable when touched. Regarding vital sign, bradycardia and hypothermia, it will signify severe and life-threatening malnutrition. Inappropriate or inadequate weaning practice and chronic diarrhea are common findings in developing countries. Stunting resulted from combination of malnutrition, especially micronutrient and recurrent infections. In kwashiorkor, there is inadequate protein intake, while the total calorie intake will be ranging from fair to good. The patients will have hypoalbuminemic state, which will result in a pitting edema that usually starts in the lower extremities and ascend upward with increasing severity. Other factors that contribute to the condition is acute infection, toxin, and specific micronutrient or amino acid imbalance. They are likely to contribute to the etiology of the condition. The major clinical manifestation of kwashiorkor is that the body weight is near normal for age. So weight alone does not accurately reflect the nutritional status of the patient because the patient will have an edema. During physical examination, we can see that the patient will have relative maintenance of subcutaneous adipose tissue with marked atrophy of muscle mass. The patient will have edema in various degrees. Some will have minor pitting edema of the dorsum of the foot. However, others may have more severe degree of edema with generalized edema, involvement of the eyelids and scrotum. The hair of the patient with a kwashiorkor will be spare, dull, easily pulled out. It may range in color from brown, red, or may be yellow-white. Upon refeeding of the patient, the hair will start to restore its normal color. So it will leave a band of hair with altered pigmentation followed by a band with normal pigmentation. This alteration in the color will give characteristic sign which is called flag sign. Skin changes in patient with kwashiorkor, it may range from hyperpigmented hyperkeratosis to an erythematous macular rush, pellagroid rush on the trunk and the extremities. The characteristic rush of patient with kwashiorkor, it is called flaky paint rush. This type of rush represents a superficial desquamation that mostly occur over the pressure surfaces, for example, in the knee, the groin, and in the elbow. The patient with kwashiorkor may have other features of vitamin deficiency like angular chelosis, atrophy of the filiform papillae of the tongue. They may also have fungal infection of the mouth, monilial stomatitis. On examination, the patient will have mood facies, which will result from enlarged parotid gland associated with facial edema. The patient have apathic facies, that is disinterested in eating. The abdomen will be distended, and upon examination, the patient will have enlarged soft liver with indefinite edge. Lymph node and tonsil are commonly will be atrophic. And on examination of the chest, you may find basal crepitation. So the characteristic feature of patient with protein energy malnutrition, regarding face, the patient either will have moon face, like in kwashiorkor, or the patient with marasmus will have an old man simian facies. In the eye, you can see signs of vitamin A deficiency, a dry eye, pale conjunctiva, and bitot spots. In the mouth, we'll have features of riboflavin deficiency like angular stomatitis, cheilitis, glossitis. May found signs of vitamin C deficiency like spongy bleeding gums, or a patient will have parotid enlargement. In the teeth, you may find patient have enamel mottling or delayed eruption. Regarding hair, the hair usually appear dull, spare, easily pulled out. The patient may have flax sign, and also some of them will having alopecia. The skin is usually loose, wrinkled in patient with marasmus. On the other hand, patient with kwashiorkor, because of the edema, the skin will appear shiny. The patient will have a crazy paving, flake paint dermatosis. Regarding nail, the patient will have an iron deficiency, will have koilonychia, thin, soft nail plate. The patient may have fissure or ridges. Also, the patient will have muscle wasting, especially in the buttocks and the inner aspect of the thigh. May have signs of hypocalcemia. Regarding skeletal, the patient will have different kinds of deformity as a result of calcium, vitamin D, and vitamin C deficiency. The abdomen may be distended, either from hepatomegaly with fatty liver or from ascites. Also, the patient may have a bradycardia, hypotension, reduced cardiac output, or other part of vasculopathy. The patient may have global developmental delay or just loss of reflexes like knee reflex, ankle reflex. Regarding hematology, the patient may have pallor, petechiae, bleeding diathesis, and so on. And the general condition of the patient may be lethargic or irritable on handling. Assessment of nutritional status. Malnutrition must be recognized and accurately defined in order for making an early decision about refeeding. Evaluation is divided into assessment of past and present dietary intake, anthropometry, and lastly, it will be supported by lab assessment. Dietary assessment includes asking the parent of the child to record the food intake of the child over several days. The anthropometry include measuring the weight, the height of the child. In addition to that, we can measure the subcutaneous fat store by skin fold thickness over the triceps. We have many calibers that can be used to measure skin fold thickness. One of the commonly used is the Harpenden uh, caliber, which is shown in the figure 8. While it's difficult to measure the skin fold thickness accurately in young children, we have what is called a mid-upper arm circumference. This is easily be made, can be repeatedly used, and it is independent of the age in a children from 6 months to 6 years. We have to measure it at the midpoint between the acromion and the olecranon, and we have to use a non-stretched tape measure. The lab investigation, it is useful in detection of early physiological adaptation to malnutrition. However, clinical history, examination, and anthropometry are of greater value than any single biochemical or immunological measurement. Treatment of a patient with protein energy malnutrition, it usually involves three phases. The first stage is stabilization phase, which is last in the first week. Second stage is rehabilitation phase, which is last from the second week up to the sixth week. And the last will be follow-up phase, which is started from the seventh week until recovery. The first phase is the stabilization phase, which is include the first week of therapy. It involves treatment, prevention of infection, hypoglycemia, anemia, dehydration, correct any electrolyte abnormality, and vitamin micronutrient deficiency, however, except iron. Usually we start with feeding with F75 formula, which means the formula that gives 75 kilocalorie per 100 cc. The second phase of therapy is rehabilitation phase, which is started from the end of the first week up to the sixth week of treatment. It involves feeding with F100 formula, which is giving 100 kilocalorie per kg per day. If oral feeding is not tolerated in this phase, we can give it by NG tube. The third phase and the last one is the follow-up phase, which is started from the beginning of the seventh week until the patient recovery. Usually it's done by feeding to cover catch-up growth and also by provision of emotional stimulation with the aid of family and the community. Refeeding syndrome. This is usually a collection of electrolyte, vitamin, and mineral anomaly that's seen upon refeeding a patient with acute severe malnutrition. It's mostly characterized by development of severe hypophosphatemia as a result of cellular uptake of phosphate that occur during the first week of therapy. The other features, in addition to hypophosphatemia, the patient will develop hypokalemia, hypomagnesemia, hypernatremia, hyperglycemia, and vitamins deficiency, especially thiamine. The clinical manifestation of refeeding syndromes predominate by clinical feature of hypophosphatemia, especially when the patient develop a serum phosphate level is less or equal to 0.5 millimole per liter. The patient will have weakness, rhabdomyolysis, seizure, altered consciousness, and lastly, the patient may have cardiac arrhythmia, sudden death. During management of the patient, we have to do close monitoring of the serum phosphate level, potassium, magnesium, calcium. These all should be measured frequently during the first 2 weeks after starting therapy. Treatment by slowly increase feeding with supplementation of these minerals, especially phosphate, and vitamins, especially thiamine, as well as correcting any electrolyte disturbances, especially hypokalemia and hypomagnesemia. Complications of malnutrition. As a complication as malnourished children, they are more susceptible to get infection, especially sepsis, pneumonia, and gastroenteritis. Hypoglycemia is common after period of severe fasting. However, it may also be a sign of sepsis. Hypothermia may be seen and it will signify infection with bradycardia and may signify a decreased metabolic rate to conserve energy. Bradycardia and poor cardiac output predispose the malnourished child to heart failure. Also, the patient may have micronutrient deficiency. Vitamin A and zinc deficiency are common in developing wards. They are important causes of altered immune response and increased morbidity and mortality. Water soluble vitamins. Water soluble vitamins are not stored in the body except for vitamin B12, so intake will alter tissue level. Ascorbic acid. A deficiency of vitamin C, it will result in the clinical manifestation of scurvy. Infantile scurvy is characterized by irritability, tenderness of the bone, with swelling, and pseudoparalysis of the legs. It may occur if the infant are fed unsupplemented cow's milk in the first year of life, or if the diet is devoid of fruit and vegetables. The patient will have bleeding tendency like subperiosteal hemorrhage, bleeding gums, petechiae, hyperkeratosis of the hair follicles, and succession of mental changes which is characterized of the progression of the illness. The patient eventually will develop anemia secondary to bleeding, a decreased iron absorption, or abnormal folate metabolism are seen in chronic scurvy. Thiamine deficiency occur in alcoholics, it also been reported in adolescents who have undergone a bariatric surgery of severe obesity. Infantile beriberi, it occurs between the age of 1 to 4 months in a breastfed infant whose mother have a thiamine deficiency, if the mother, for example, are alcoholic. An infant with protein calorie malnutrition and an infant who is receiving supplemented hyperalimentation fluid. Also, it is seen in infant who is receiving boiled milk. An acute wet beriberi with cardiac symptom and signs predominate in infantile beriberi. Patient will have anorexia, apathy, vomiting, pallor, which progress to dyspnea, cyanosis, and death from heart failure. Infant with beriberi have characteristic aphonic cry, as the patient will appear to be crying, however there is no sound is uttered. Other signs, the patient will have peripheral neuropathy and may have paresthesia. Riboflavin deficiency is called a riboflavinosis. It is characterized by angular stomatitis, glossitis, chelosis, seborrheic dermatitis that's seen around nose and mouth. The patient may have eye changes, which is seen as reduced tearing, photophobia, corneal vascularization, and the patient may have cataract. Subclinical riboflavin deficiencies have been found in patients with DM, in children in families with low socioeconomic status, and also in patients with chronic cardiac disease, and those patients who undergo prolonged phototherapy for hyperbilirubinemia. Patients with niacin deficiency will have what's called pellagra, which is characterized by weakness, lassitude, dermatitis, photosensitivity, inflammation of the mucous membrane. The patient may have diarrhea and vomiting, dysphagia, and in severe cases will have dementia. Vitamin B6 pyridoxine is destroyed by heat. So heat treatment was responsible for vitamin B6 deficiency and seizure in infants who is fed an improperly processed formula. Also, a cow's milk is deficient in vitamin B6. Dietary deprivation or malabsorption of vitamin B6 in children result in hypochromic microcytic anemia, vomiting, diarrhea, failure to thrive. Patient also may have seizure. Children who receive isoniazid or penicillamine also may require additional vitamin B6 because these drugs will bind to this vitamin. Folate deficiency is characterized by macrocytic anemia with hypersegmented neutrophil. Folate deficiency may result from low dietary intake, malabsorption, or vitamin drug interactions. Deficiency of folate can occur early in the newborn period within weeks of delivery. This is because the infant requires 10 times as much folate as adults relative to body weight. In addition, the patient will have a scant store of folate in the newborn period. Folate is heat labial. So heat sterilizing home prepared formula, it can decrease the folate content by half. Also, evaporated milk and cow's milk are low in folate. Patients with chronic hemolysis like sickle cell anemia, thalassemia, they may require an extra folate to avoid deficiency because of relatively high requirement of the vitamin to support erythropoiesis. First occurrence and recurrence of a neural tube defect are reduced significantly by maternal supplementation of folate. B12 deficiency. Although vitamin B12 deficiency during childhood is rare, an early diagnosis and treatment of this condition is very important because of risk of irreversible neurological damage. Regarding cause, most cases of childhood vitamin B12 deficiency result in the defect in the absorption. It may result from congenital pernicious anemia, in which there is absence of intrinsic factor, or juvenile pernicious anemia, in which there is an autoimmune condition, or there is deficiency of transcobalamin transport. Gastric intestinal resection and small bowel bacterial overgrowth also may result in vitamin B12 deficiency. Infant who's exclusively breastfed who's ingest adequate vitamin B12 unless the mother is strict vegetarian without supplementation. Depression of serum vitamin B12 and the appearance of hypersegmented neutrophil and macrocytosis are early clinical manifestation of the deficiency. Also, it may result in a neurologic manifestation in which include depression, peripheral neuropathy, posterior column sign, dementia, and the patient may end up with coma. It's very important to see that the patient with neurological signs do not occur in a folate deficiency, but administration of folate may mask the hematologic sign of B12 deficiency, while the neurological manifestation will continue to progress. So patient with B12 deficiency also may have increased urine level of methylmalonic acid. Most cases of B12 deficiency in infant and childhood are not of dietary origin. The majority of the patient will require lifelong treatment. Maintenance therapy consists of repeated monthly injections intramuscularly, although recently a form of vitamin B12 is administered intranasally. Fat-soluble vitamins. In comparison to water-soluble vitamin, the fat-soluble vitamin generally have stored in the body, so dietary deficiency generally develop more slowly than that for those with water-soluble vitamins. Absorption of the fat-soluble vitamins depend mainly on the normal fat intake, digestion, and absorption. Vitamin A. The clinical manifestation of vitamin A deficiency in a human appear mainly as ocular sign, which is termed xerophthalmia. The earliest symptom is night blindness. Then the patient will develop xerosis of the conjunctiva and the cornea. And if the condition left untreated, it will result in ulceration, necrosis, keratomalacia, and the patient may end up with a permanent corneal scar. In addition to the ocular sign, clinical and subclinical vitamin A deficiency are associated with immune deficiency. The patient will have increased risk of infection, especially measles, increased risk of mortality, especially in developing nations. Xerophthalmia and vitamin A deficiency should be urgently treated. On the other hand, hypervitaminosis A is also having serious sequelae, including headaches, pseudotumor cerebri, hepatotoxicity, and teratogenicity. Vitamin E deficiency is seen in children with fat malabsorption, which could be seen secondary to liver disease, untreated celiac disease, cystic fibrosis, and a beta lipoproteinemia. In those patients, if lifted without vitamin E supplementation, the patient will develop a sensory and motor neuropathy. The first sign of deficiency is loss of deep tender reflexes. In a preterm baby at 1 to 2 months of age having hemolytic anemia, which is characterized by elevated reticulocyte count, also the patient will have peripheral edema and thrombocytosis. All the abnormalities are corrected after oral, lipid, and water-soluble vitamin E therapy. Vitamin K deficiency in the newborn period, it will result in what's called hemorrhagic disease of the newborn. This disease is more common among breastfed infants, which occurs in the first few weeks of life. It is rarely seen in infants who receive prophylactic intramuscular vitamin K on the first day of life. It's usually marked by generalized ecchymosis, GIT hemorrhage, bleeding from circumcision or umbilical stump. Intracranial hemorrhage also can be seen, however, it is uncommon. Therefore, the American Academy of Pediatrics recommend that parenteral vitamin K in a dose of 0.5 to 1 milligram be given to all newborn shortly after birth. Vitamin D deficiency, it results in rickets in children and osteomalacia in postpubertal adolescents. Inadequate direct sun exposure and vitamin D intake are sufficient causes, but other risk factors, such as various drugs, for example, phenobarbital, phenytoin, and a condition like malabsorption, may increase the risk for development of vitamin deficiency rickets. Breastfed infants, especially those with dark pigmented skin, are at risk for vitamin deficiency.